Hello. Mr. Musetti is a 60-year-old male with multiple comorbidities and polypharmacy, which increases the risk of significant drug-to-drug interactions. The two drugs I'll be focusing on are simvastatin and ketoconazole. Simvastatin is in the drug class of statins and is otherwise sold under the brand name Zocor. It treats high cholesterol levels by lowering the amount of low-density lipoprotein, LDL, cholesterol in the blood. This bad cholesterol builds within arteries, restricting or fully blocking blood flow, which is known as atherosclerosis. It is driven by oxidation of LDL within the arteries, forming into foam cells, causing a plaque buildup. This is the underlying cause of coronary heart disease, CHD, and is the reason behind administration of the drug in Mr. Musetti's case. Within the liver, HMG-CoA reductase, HMGR, regulates the production of mevalonate, which creates cholesterol. Mevalonate is required to produce very low-density lipoprotein, VLDL, which is then released into the bloodstream, turning into LDL as muscle and adipose tissues extract triglycerides from VLDL into their cells. A reduction in HMGR achieved through simvastatin administration downregulates the chain production of LDL, reducing its buildup within arteries. The liver, now in need of cholesterol due to a decrease in production, increases LDL receptors on hepatocytes and transports excess cholesterol from peripheral tissues back to the liver via high-density lipoprotein in the process called reverse cholesterol transport. LDL levels are then reduced within the circulatory system. This process is utilised within individuals with CHD such as Mr. Musetti, where simvastatin is taken orally to inhibit HMGR. Simvastatin competitively inhibits HMGR due to the drug structurally resembling HMG-CoA, binding to the enzyme's active site. This reduces the likelihood of HMG-CoA binding, therefore decreasing the enzyme's apparent affinity for its substrate without changing the maximum reaction rate due to high substrate concentrations having the ability to overcome the inhibition. Onychomycosis is a fungal nail infection commonly caused by dermatophytes, which are a class of fungi that feed on the keratinized nail and surrounding tissues. This results in nail thickening, discoloration, and structural breakdown, and is the reason for treatment with ketoconazole in Mr. Musetti's case. Ketoconazole is an imidazole antifungal medication used to treat fungal skin infections and dandruff, commonly sold under the brand name Nizoral. It works by inhibiting an enzyme named lanosterol 14-alpha demethylase, a type of cytochrome P450 enzyme. The enzyme is crucial in biosynthesis of lanosterol into ergosterol and is essential for maintaining fungal membrane stability and integrity. This causes a decrease in ergosterol production, increasing the fluidity of the membrane, making it weak and dysfunctional. This leads to the fungostatic effect, inhibition of fungal growth, and the fungicidal effect at higher concentrations. The drug can also target human cytochrome P450 enzymes, which can have a side effect of slowing the metabolism of other drugs. The cytochrome P450 enzyme system is predominantly expressed in hepatocytes and controls an estimated 80 to 90% of enzymatic drug metabolism. Therefore, an understanding of the interactions that ketoconazole can have is crucial during assessment of Mr. Musetti. The interaction between simvastatin and ketoconazole is primarily seen at the level of hepatic drug metabolism. Simvastatin is a lipophilic statin that expresses first-pass metabolism in the liver via the cytochrome P450 isoenzyme CYP3A4. This pathway is essential for the conversion of the drug into inactive metabolites, which regulates its plasma concentration. Ketoconazole, in addition to inhibiting fungal ergosterol synthesis, is a potent inhibitor of CYP3A4. This is achieved through the binding to the heme ion component of the cytochrome P450 enzyme, inhibiting its oxidative metabolic activity. When CYP3A4 is inhibited, the metabolic clearance of simvastatin is exceedingly reduced, resulting in an accumulation of simvastatin within the systemic circulation. This leads to increased bioavailability and extended exposure of the drug to tissues. This elevation in concentration creates a risk of side effects that are usually dose-dependent, such as skeletal muscle toxicity. At the cellular level, excessive statin exposure disrupts muscle cell membrane integrity and mitochondrial function. This contributes to the contraction of myopathy, or in severe situations, the contraction of rhabdomyolysis. Although in Mr. Musetti's case, ketoconazole is administered topically at 2%, which significantly limits systemic absorption and reduces its ability to inhibit hepatic CYP3A4. While the interaction between drugs is significant, its realistic impact is minimal due to ketoconazole being applied topically, although not completely absent. The interaction between simvastatin and ketoconazole is classified as a pharmacokinetic interaction, specifically the inhibition of drug metabolism. Pharmacokinetic interaction occurs when one drug alters the absorption, distribution, metabolism, or excretion of another drug, where in Mr. Musetti's case, the primary mechanism involves hepatic metabolism. It is not a pharmacodynamic interaction, which is defined by the drug's effect on the body. Simvastatin utilizes the CYP3A4 enzyme for its metabolic breakdown. Ketoconazole inhibits this enzyme, therefore reducing the rate at which simvastatin is metabolized and excreted from the body. This leads to a change in the pharmacokinetic profile of simvastatin, increasing its plasma concentration, half-life, and bioavailability. This ultimately causes prolonged exposure and an increased risk of muscle toxicity. Therefore, the classification of the drug-to-drug interaction is pharmacokinetic, involving CYP3A4-mediated metabolic inhibition. In Mr. Musetti's case, it is important to appreciate the topical administration of ketoconazole, therefore limiting the extent of this pharmacokinetic interaction. Even though ketoconazole is used topically at 2%, broken skin or excessive application can cause an increase in systemic absorption. In severe cases of muscle toxicity, rhabdomyolysis can be contracted. This breakdown of muscle releases myoglobin, which is nephrotoxic and can accumulate in renal tubes, causing acute kidney injury. This can decrease glomerular filtration rate, GFR, and subsequently increase blood urea nitrogen levels, BUN, and serum creatinine. Within Mr. Musetti's case, where he presents an already reduced renal function, any additional renal damage such as myoglobin-induced nephrotoxicity can exacerbate existing damage. Coupled with his age of 60, he may present an increased drug sensitivity due to a decreased metabolic capacity. Additionally, gout and type 2 diabetes mellitus are linked with reduced kidney function, which places Mr. Musetti at an increased risk for further renal damage. While there are no symptoms of muscle weakness or pain, this absence does not reduce the risk of statin-induced toxicity. Tests for creatine kinase levels would be beneficial to determine if muscle damage is present. Therefore, the topical administration of ketoconazole reduces the likelihood of an interaction, but the presence of reduced GFR, age, and existing comorbidities means that a slight increase in simvastatin concentration could lead to clinically major consequences. When managing patients in physiotherapy, it is highly relevant to understand drug-to-drug interactions, especially with patients that have an extensive medical history and polypharmacy. In Mr. Musetti's case, increased simvastatin levels may lead to statin-induced myopathy, which displays itself as muscle pain, weakness, and reduced function. This could easily be mistaken for musculoskeletal conditions commonly treated within physiotherapy. Failure to distinguish primary musculoskeletal injury and pharmaceutical-induced myopathy can lead to incorrect diagnosis and treatment. During exercise prescription, patients at risk of myopathy must be educated in understanding the risks and consequences of unusual fatigue or pain. Physiotherapists must monitor patients' response to exercise and identify red flag symptoms associated with drug effects, such as profound muscle pain, weakness, and dark-colored urine. If these symptoms were present, referral to a medical practitioner is essential to avoid further damage, including acute kidney injury. Therefore, understanding of drug-to-drug interactions increases clinical reasoning skills and promotes safe, patient-centered care within physiotherapy. Following shows the reference list of all sources used within this assignment. Also, the music used is originally created by me.